To thank you for your brief introduction. As you mentioned today, the webinar will be focused mainly on the innovative solutions of Smartee and how can they help us in achieving a more predictable and a more efficient treatment in Class 2. Class 2 malocclusion has always been a challenge, and by unveiling today the solutions that are offered by Smartee, we can reshape the landscape of treating Class 2 malocclusions. So allow me please to share my presentation. So throughout today's session, we will uncover how Smartee solutions are improving the treatment of Class 2 malocclusions. We're all familiar with the Smartee solutions, and today I will shed some light on some of those solutions in details, and how can we benefit from those solutions in terms of treating Class 2. So generally speaking, when we talk about Class 2 treatment options, after we do a proper diagnosis for the case clinically and radiographically, we need to know that those cases should be treated on a basis of either a dental movement or a skeletal movement. So when the patient have a complaint about the profile and the facial appearance, we should consider the skeletal options. And if the patient has an acceptable profile and has no complaints about the facial appearance, we can do the only dental movement. So dental movement mainly are distalization and extraction, while the skeletal we can consider functional appliances and surgery. So let's first talk about the dental problems in terms of Class 2 malocclusions. And always we have these questions in our mind, whether to distalize or extract in such cases. So whenever you have a patient came into your office and you need to do the diagnosis for this case, you need to know which treatment option is suitable for that case. There are certain parameters and factors that need to be considered before jumping into this solution. First, we need to evaluate and diagnose and assess the cases in the 3 depths of malocclusion: sagittally, transversely, and vertically. So first, if we talk about the sagittal relationship in terms of overjet to be corrected. So we know that aligners can treat Class 2 malocclusions, and we know that distalization is one of the most predictable movement to be achieved, but it also has a limit. So if the overjet of the patient is extremely severe, we should consider doing the extraction for those cases, while in terms of around 3 to 4 millimeters, we can consider the distalization option. Another factor to be considered is the possibility of expansion in terms of transverse relationship. So whenever we have a patient of Class 2 and we need to correct this increased overjet, we have the option and the possibility of expansion. And again, we know that expansion is one of the predictable movement to be achieved by aligners. So if the patient have the chance and the possibility to do expansion, we could use this instead of extraction. And we need to check at the inclination and the torque of the posterior teeth in order to check the feasibility of the expansion for that patient. In terms of the vertical relationship, so we need to check the initial overbite of the patient, whether it's deep bite or open bite. We know that expansion and the non-extraction treatment can open the bite, so it is favorable in cases of deep bite, while we can make use of the extraction and the retraction of incisors to close the bite, because when we do the retraction, we have the relative extrusion, which closes the bite. We need also to consider whether the patient came with an initial incisor inclination, whether they are inclined or proclined. So if the patient came, for example, with Class 2 Division 1 with extremely proclined upper incisors, in that case, the expansion and further proclination will not be applicable, and we should consider about other options. The amount of space discrepancy, if the patient has significant amount of crowding, and the expansion, distalization cannot solve this issue, we should also consider to have an extraction. And the most important parameter and the factor is the patient profile. So when the patient came with the class 2 malocclusion with a very protrusive profile, in that cases, it might be not advisable to have a further proclination or to depend mainly on the distalization. In these cases, we should consider another options like an extraction. Also, the presence of third molars are one of the factors that need to be considered when we plan the distalization, because sometimes it might interfere with the distal movement of the molars. So I talked briefly about those factors, and throughout today's session, we will show some cases, and we will see how these factors are to be considered in treatment planning of class 2 malocclusion. So we all use aligners, and we need to check how predictable are the movements. Unfortunately, we don't have a strong evidence based about all the kinds of movement, but recently I have seen this blog comparing different kind of orthodontic tooth movement and how predictable they are, and it shows that one of the most predictable movement that can be achieved by distalization by only aligners and attachments is the distalization. It is accurate up to 88%, but nonetheless we have to assess the success rate of this distalization, and it's not only about how much millimeter of distalization we can achieve, but rather how to maintain this and to avoid any unwanted movement and side effects. Distalization process is very predictable with aligners. We can start it from the beginning, and we just need to know how to reinforce this anchorage and how to achieve the distalization process more efficiently. So we need to plan the distalization very carefully and to avoid any obstacles that we might find in our path, because when we apply the distal forces to the maxillary molars, we are expecting to have a side effects, not only in terms of distal tipping of the molars, but rather than we have the side effect of the anterior and proclination of the upper incisors. Moreover, we have also an anchorage loss during the subsequent stage of anterior retraction. So after we finish distalizing the molars and we want to start retracting the anteriors, also we have to pay attention for the anchorage, because the molars might tend to move mesially again, and all the amount of distalization we gained from the first stage can be lost. So the most important factors to consider and the parameters during distalization process is how we stage this distalization movement and how to reinforce our anchorage during doing so. And I know that this might be basic for some of you who are already doing some distalization, but I need to go through them briefly. And we need also to assess how Smartee solutions are contributing to making those movements more achievable. So Smartee has developed their sequential distalization protocol, which is Smartee S7, which means that we do only 2 molars at the time. So when we start this movement, we do the semi-sequential distalization up to 50%, which is the typical V pattern. It is available in Smartee and also many other companies, which means that only 2 molars move at the time. So for example, if we have the second molar moving distally in 10 aligners, after achieving 50% of this distal movement, the next molar will start moving. So after aligner number 5, the first molar will start to move, and then after also 5 aligners, the second premolar start to move, and so on. While for anteriors, there is the option of having them retracted as a whole together, or we can modify this with the frog pattern for anteriors, which means if we finish the distalization of the molars and we start retracting the anteriors, the canine will be retracted first by 1 millimeter, followed by anteriors, then canine again, then anteriors, until we finalize the movement. So this modification, when we use it when we have a significant amount of anterior retraction, and also for aesthetic reasons for the patient, in order not to having like a big gap distal to the laterals, we can have this frog pattern to avoid having this big gap distal to the laterals. Another protocol for distalization that we can do is the full sequential distalization, which means only one molar moves at a time. So we use this technique when there is like a significant amount of retraction and we have a high anchorage demand, and in some cases where we cannot reinforce our anchorage. So we choose this option where only one molar moves at the time. So in some cases, like in this case, we are distalizing in both arches, upper and lower. So we can even use TADs to reinforce the anchorage, or we can use the 100% sequential distalization. So in terms of anchorage, we need also to consider reinforcing the anchorage during distalization of the molars and during anterior retraction, in order to achieve a more stable and more predictable result. So what Smartee offers in terms of solutions that help in these movements are really amazing. So we know that during distalization process, we need to run class 2 elastics for most of those patients to have a more predictable distalization. But what Smartee offers is the class 2 elastics on a Smartee hooks or button, which is S15. So usually when we plan for class 2 elastics, you can ask the technician for your preference, whether to have button cutouts or hooks. Also, you can choose whether you want to apply it to the first or second molars in the lower, and whether you want to apply it for the canine or premolars in the first premolar in the upper. But we always face issues when we have these buttons, such as breaking and debonding of the buttons. Another thing is that we cannot apply attachment on the tooth which has the elastic hooks. It might interfere with the position of the elastics. And another thing is that when we do the button cutout and the hooks, we are compromising the surface area of the plastic covering and wrapping the tooth. And we all know that the aligners' main idea is to have as much possible of the tooth surface covered by the plastic material. So to overcome all of these drawbacks, Smartee has came with a solution of the integrated hooks and buttons within the aligners. So instead of applying the force to a single tooth, these hooks will ensure that the force is applied to the entire arch instead of the single tooth. Another advantage is that we can apply it interdentally between the teeth. So if you want to place attachments on the adjacent teeth, you can do you can place the attachment of your choice without any interference, and you don't have to worry about these buttons being debonded or fell down, because we know that the patient with the aligners, they have the privilege of removing their aligners. They can eat whatever they want. They don't have to avoid any hard food. So by having those buttons bonded on the teeth, the chance of debonding is really high. But when we have those hooks integrated within the aligner, we don't have to worry about this anymore. We can place the attachments that we want. We can even detect which position we want to place them, whether it's more anterior, if we want to have a more horizontal vector of force, or if you want to place it also more posterior in the lower arch. So this innovation developed by Smartee is really saving time, in the chair side time, by having to avoid bonding any buttons. So they are both integrated within the aligners, apply the force to the whole arch, we avoid button breakage, And also we avoid the weakening, the retention of the aligners, because sometimes when the patient apply the elastics on the hooks, it might interfere with the retention of the appliance, and sometimes the aligner can be dislodged from the patient's mouth. So what Smartee is also offering in terms of anchorage, which is the first aligner company to use the palatal mucosa of the patient. In fixed appliance, we know that we have a lot of anchorage devices that can be placed during retraction or during extraction cases, such as the Nance appliance or the transpalatal arch. So Smartee, what they do is they use this technology and they incorporate it inside their aligner. So they have this innovation of having the clear Nance and the clear TPA, which are really helpful in cases of distalization. So the clear Nance is an appliance which is placed behind the upper anterior, behind the incisors, in the palatal roget area of the patient, which is called Smartee S11. And this feature will help reinforcing the anchorage while we are doing the distal movement of the molars. So to avoid the side effect of proclination of incisors, we can use this technology. On the other hand, when we finish distalizing the molars and when we start retracting the anteriors, the chance of having those molars move back again mesially and losing the amount of distalization that we gained from the first stage is also high. So in order to avoid this, Smartee has developed that clear TPA, which connects the premolar and molar areas of both sides, making them as a strong anchor units, and that will resist the mesial movement of the molars when we retract the anterior teeth. We can also apply the clear TPA in extraction cases to reinforce the posterior anchorage and to resist the mesial movement of the molars when we retract the canine and the anteriors. Another solution, which is S2, that is developed by Smartee, is the invisible lip bumper. This is an increased thickness of the aligner material, just labial to the incisors. The mode of action of this lip bumper is to transmit the forces of the lip to the upper incisors and resisting any forward and any proclination movement of the incisors. We can apply them, for example, if we run class 2 elastics, as a side effect, the lower incisors will be proclined, so we can apply it on the labial surface of the lower incisors. Moreover, we can also apply it to the upper incisors during distalization. So as I mentioned earlier, when we move the molars distally, the upper incisors tend to procline. So if we have this lip bumper behind the upper incisors, the force of the lip will exert some pressure on the upper incisors, resisting this unwanted side effect. The only disadvantage about this, which I used in some of my cases, is that the patient in the first couple of days, they might feel that the lips is more prominent, but with the time they get used to it. So to summarize, Smartee has helped us in reinforcing the anchorage during distalization by applying Smartee hooks and button, utilizing the palate by using the clear Nance and TPA, and using also the lip of the patient by having the invisible lip bumper. And of course, if we need more anchorage, if we need more distalization to be achieved, we can use the mini implants. So talking about S11, Smartee has not only used the palate for the patient as an anchorage, but they have developed also the clear expander. So this is different from the clear TPA by applying an actual force that helps in expansion. So this horizontal rods are expansion sheet connecting the premolars or molar area on both sides, which are able to have an expansion force of 350 to 100 grams of force What happened in these scenarios is that the patient having the aligner like 0.5 millimeter wider than the actual arch width. So when the patient inserts the appliance, it will exert the force and the tension force that is can stimulate the expansion. So we know expansion is a predictable movement using aligners, generally speaking. So imagine if we have also the clear expander. It will add more predictability and more efficiency to the expansion process. So by utilizing these palatal appliances, we ensure a precise tooth movement. We ensure that minimal side effects of the unwanted movement can be resisted, and it will contribute to the overall treatment outcome. Okay, so allow me to share some of the cases of class 2. So this is a 25-year-old female. She came to my office complaining from protrusion of her upper teeth. She had proclined upper incisors, class 2 canines on both sides, but her profile is really acceptable and she has no complaint about her facial appearance. The X-ray, we can see that the upper incisors are proclined and the patient has no skeletal discrepancy. So again, if we get back to the parameters that I mentioned earlier, so how about the amount of space discrepancy? In this case, it's very moderate. The patient doesn't have a lot of crowding that requires a lot of space. The amount of overjet is around 4 millimeters. Initial incisor inclination, they are proclined, and we can do expansion. As we can see that the posterior teeth, they have the torque that is required for expansion, and the patient has a really good profile with no complaints. So in this case, is it an extraction case? Definitely not. Can we do expansion? Yes, we can do. How about IPR? We can do that, but I didn't plan it in that case. And finally, distalization. Of course, this is a distalization case because we don't need to distalize as much of space, and the incisors are initially proclined. So we need to be careful when we plan the anchorage in order to avoid any further proclination. So that was the final setup for that case. We do distalization of up to 2.5 millimeters. And we reinforce the anchorage with class 2 elastics. And in order also to maintain the proclination of upper incisors and preventing any further mesial movement, a clear nance was applied. So in 45 aligners, which is almost 11 months, we changed the class 2, the canines into class 1. The upper incisors proclination is fully corrected. The arch is very well developed and expanded with the clear expander we used. No IPR was done in this case. And also no significant change in the profile, which was already acceptable. So the X-ray, the superimposition, we managed to change the upper incisor inclination from this to that, and that's the pre and post tap. So what was the treatment protocol for this case? We do semi-sequential distalization 50% according to Smartee S7 solution. We did expansion of both upper and lower arch, and we incorporate the S11 clear expander in the upper arch. And for anchorage reinforcements, we use class 2 elastics and the clear nance, as we already start with the proclined incisors, and we need to avoid any further proclination. Another case is a 28-year-old female. And this patient, she came to my office and she was complaining about the retraction of the retroclined upper incisors and her gummy smile. She has class 2 division 1, and also the profile is very acceptable. And honestly, this patient, she was going to Google and checking her condition, and she said, I have class 2 in my molars and canines, and I want to correct that. So it's amazing how Google now works and how patients, they can go and diagnose their own cases. So with X-ray, the patient has an acceptable skeletal relationship, and the incisors are a bit retroclined. And again, by checking the parameters, the patient doesn't have that amount of space discrepancy, and the incisors are initially retroclined. We can expand looking at the torque and the retroclination of the buccal segment, and the patient has a very acceptable profile. So what we need to correct in this case is trying to achieve a better relation in the buccal segment, procline the upper incisors, which are initially retroclined, and trying to correct the gummy smile. So the initial setup of the patient, again, if we talk about the options of this case, definitely it's not an extraction case. Looking at the profile of the patient and the initial incisor inclination, we can expand, yes, as the arch is already constricted. IPR, yes, we can do IPR, which is also not planned in that case, and definitely we will go through distalization. So that was the final setup. We do some distalization up to 3 millimeters in both sides. And then for the upper incisors, we procline, then retrocline and intrude. So the important factor is to consider in this case is before we do any retraction of the anteriors, we need to procline them first to avoid losing the anchorage and to avoid further retraction of the incisors. So I mentioned earlier that when we do distalization of the upper molars, we're having the side effect of incisors being proclined. So in that case, this side effect is wanted. It works in my favor. So we will not reinforce the anchorage heavily on the anterior. We will just use class 2 elastics, which we will be run on the Smartee hooks. So this case is still ongoing. Still, we didn't finish that case, but let's see how the progress of this case. After 12 aligners only, we finished distalizing the molars, and after 20 aligners, we finished distalizing the premolars, and now we have those nice gaps behind the canines. So in about 5 months, we finish the distalization and we will start retracting the anteriors. So let's see how the buccal segment has moved from class 2 into class 1. We still have a lot of work to do. But the interesting part of this case is that incisors, by just having the distal force, they are already proclined and intruded a little bit, which is the side effect of distalization. So we can see that the gummy smile has improved a little bit. The incisors were intruded. We apply the Smartee hooks, class 2 elastics. Can have a look at the incisors inclination. It has been improved significantly within just 20 aligners. And the protocol was, in this case, to have distalization semi-sequential as well. We have expand both upper and lower arch with S11 in the upper arch. We procline incisors, then retract and intrude, which is very important to have them in this order. And for anchorage, we have the class 2 elastics on Smartee hooks. No need to have the clearness because I want this proclination with the incisors. So what's the distalization protocol when using Smartee? When we start the distal movement of the molars and I need to reinforce my anterior anchorage, we can ask the technician to have this clear nance in order to prevent the mesial movement of the molars. And after we finish the distal movement of the molars and we start retracting the anteriors, we can apply the clear TPA. So these solutions are unique, and by utilizing them, we can ensure that the distalization will be going very smoothly and very predictably. Okay, so let's move to another cases where the patient has a skeletal discrepancy. So this young 11 years old boy, he came with a skeletal class 2, and he had the 3 depth of malocclusion, deep overbite, deep overjet, and deep curve of speed. The lips were incompetent. The arch, the maxilla needs some expansion, and there is an increase in the amount of overjet. So by taking the x-rays, we can see that the patient have a skeletal class 2 malocclusion. And by using Smartee staff measurements, we can upload the x-ray and we can see all the angular and linear measurements that we want. We can also see the soft tissue measurements. Moreover, there is an option where the bone age can be detected for this patient based on the cervical vertebrae stages. So this patient is still growing, and he is a good candidate for functional appliances. Well, although Smartee, they claim that it can be used for adults, and they support strong evidence for these cases, and it can be also used for adults. But this patient is a growing patient. He have an AMB angle of increased, and also Smartee, they have their own classification for the skeletal malocclusion for the facial prognatism patient when they have the skeletal class 2. So according to their classification, I'm not going through details about this because it needs a whole day. And I believe we have some other webinars who discuss this in details. So this is a mandibular position originated facial prognatism, which means that we need to advance the mandible and we need to correct the deep overbite and the increased overjet at the same time. So that was the animation of the patient, and this is what we called S8, which is the SGTB, which is the sagittally guided twin block. So it's very similar to the twin block we are using, but this time it's with aligners. This appliance will help reposition the mandible of the patient forward. We can use also S11 as a clear expander to help in the expansion of the upper arch. And in terms of anchorage, we apply the invisible lip bumper to prevent the side effect of the forward movement of the mandible and avoid proclination of the lower incisors. So this is how the appliance look like inside the patient's mouth. We used S11 for expansion, the posterior bite blocks to reposition the mandible to the desired position, and the invisible lip bumper to help reinforcing the anterior anchorage. So once the patient have the appliance in mouth, we see how much the facial appearance and the profile has significantly improved. Also, the lips becomes more competent. And we're still also working on that case. Still maybe now we are 12 aligners. So what was the protocol in that case? We used the mandible repositioning technology developed by Smartee, S8, SGTB. We add the expansion of the upper arch with S11, and we reinforce the anchorage with the invisible lip bumper. So we can see how Smartee solutions are really involving in our 3D animation. and we need to pay attention and ask the technician to specifically add those features according to the case. Okay, this is the final case of 15 years old female. She has a mild skeletal class 2. She has a normal overbite and a retrognathic mandible. By looking at the profile of this patient, she has a very acceptable profile. She has class 2 molar and canine. The upper incisors are more or less upright, and we have an increased overjet. So again, if we look back at the parameters we set before, is this an extraction case? Looking at the profile of the patient and the obtuse nasolabial angle, definitely she's not an extraction case. Do we do some expansion? Yes, we can do. How about distalization? So let's see. So let's see at this initial setup. So the initial setup of this case is to treat with distalization in order to achieve a better class 1 molar relationship on the buccal segment. We can use class 2 elastics. But the thing is that the patient has a little bit retrusive lower lip, so that will not be corrected. Moreover, when we do such an amount of retraction to the upper interiors, we might also worsen the profile of the patient. So sometimes when you submit a case, you see the initial 3D animation, you don't have to approve immediately. We have to look at all of the parameters. So definitely that wasn't a good idea and an ideal treatment plan for that case, as the patient, based on the X-ray, she have a skeletal class 2, and even by looking at her profile, and actually we're not treating the X-ray, we're treating the patient's face and the patient concern. And when she came to the office, she was concerned about her retrusive lower lip. So by having the distalization option, it will not solve her concern. So again, according to Smartee classification, this case is a skeletally originated facial prognathis. So we need to involve some functional treatment in that case. But again, looking at that case, she doesn't have a deep overbite. So by having the twin block, by having the SGTB, I will need to, it will not work for this case. All what I need is to have the mandible to move forward, and therefore we have this 3D animation of the appliance, which is different from the SGTB, which is the SGHB. So the difference between the two appliances is that the twin block, the clear twin block, it has posterior blocks that can raise the bite, and gradually the thickness of the plastic decrease in order to allow for some extrusion of the molars and correcting the deep bite. But if I start with a case like that, when the overbite is acceptable, all I need is to advance the mandible forward. So we will use the SGHB, which is the herpes appliance, which involve two wings that force the mandible and reposition the mandible in a forward position. So again, in this case, we plan this appliance, and this is how it looks like inside the patient's mouth. We can see that we use also the invisible lip bumper in the lower arch to reinforce the anchorage. The mandible is advanced into a class 1 molar and canine, and this is the guide in this case. So when we take the bite of the patient, we ask the patient to move the mandible forward. So taking into consideration the molar and the canine relationship. So the treatment protocol for this case, again, it's a functional appliance case where S8 SGHB is applied. We do also expansion of the upper arch with S11, and for the anchorage we use the invisible lip bumper. So to summarize, distalization, we know that it's more predictable with aligners in general, because we can start from day 1 the mechanics of distalization process with aligners, allowing the coverage of the occlusal surface, and it will prevent the distal tipping of the crown, and it will prevent also any unwanted vertical movement as the aligner is covering the occlusal surface together with attachments. When we apply a sequential distalization protocol, we can achieve up to 2 to 3 millimeters easily without any TADs. And what Smartee offers in this domain is that they reinforce our anchorage by applying the invisible lip bumper, clear Nance TPA, and the application of Smartee hooks. So why Smartee is more efficient with class 2 correction? First, we mentioned that the distalization, or whether we are doing distalization or extraction, we can use those tools for anchorage reinforcement. If I have a patient with a skeletal discrepancy, we can use the S8 to reposition the mandible and align the teeth simultaneously. Whether we need a lot of cases of class 2, where we need to do some expansion, we can achieve a more predictable expansion by having the clear expander, and also by incorporating the integrated hooks and buttons. We can ensure that the patient is wearing the elastics most of the time. So for all those reasons, we can have less refinements and more predictable movement. So by utilizing all of these solutions, we can ensure that we have a more precise tooth movement. We can resist any unwanted side effects, and this will contribute to the overall treatment outcome in correction of class 2. So at the end, I would like to thank you all for your time and your attention, and I am looking forward to any insightful thoughts and questions.
Thank you, Dr. Amos, for your excellent lecture. All right, so there is one question, Dr. Amos, asking, if we don't use clear Nance with clear class 2 elastics, what are the chances of molar tipping or procline incisors?
Of course, there's always a chance of losing anchorage while we apply the distal forces to the molars, and that's why we need to be careful about these movements. There is a high chance of anchorage loss, but honestly, if it's a very mild movement, up to 2 to 3 millimeters, that would be minimal. Due to the fact that the aligner is covering the occlusal surface of the teeth, this will prevent the tipping. And sorry, I forgot to show you that in some of the cases that we did distalization, we took the X-ray after that, and actually the roots were parallel. So there wasn't a lot of tipping. But when we have like a significant amount of distalization, that needs to be even more controlled. And by having these tools, you can minimize the side effect of distalization, of the side effects, yes, of distalization. So there is a question here, is only dental expansion? Yes, mainly aligners are doing, like, you know, that it's doing tipping movement. So mainly most of the expansion gained from aligners, whether you use it without the clear expander, is mainly dental. If you want to have more skeletal effect, we can use the other expanders or the Smartee.
Maximum distalization can be achieved with Smartee with TADs involved?
Actually, I cannot give an exact number about that, but personally, in my experience, up to 3 to 4 millimeters, I would do it without TADs. More than that, I would use TADs. But the question is that if you need to do distalization for like 7 or 8 millimeters, so why would you have to do that? Why not to think about other treatment plan? Because it doesn't make sense to correct a class 2 by moving the molars more than like 6 millimeters. So it's not about the capability of distalization, but it's about the treatment plan of the case. So there's a question. I have a case with extraction of premolars, but they didn't apply NANS to the appliance in the third model. So should I ask for it or leave it to the company? If they see it's needed, they will provide it. Well, actually, people who are evaluating our cases mainly are technicians, and even if they're doctors, they are not responsible for the plan and for the movements. It's totally your responsibility. And if you are not clear about instructions and clear about the features that you want in your treatment plan, they will not just do it. Okay, in some cases, they might help you and telling you that this movement is unpredictable or very hard to be done, for example, without many screws. So if you want to, for example, intrude the incisors 3 to 4 millimeters, they will warn you that this movement is not achieved by only aligners. But if you want to add other features, for example, until now, I received all of my animations. Sometimes they have the button and hooks cut out. So every time you need to ask them if you want to have the Smartee hooks or buttons, or if you want to add any more of the solutions that I have mentioned. So I believe it's not the responsibility of the technician to help you or to see what's appropriate in that case. You have to show him exactly what you need to do and add.
Thank you, doctor. And we got a new question asking how much of expansion is feasible without clear expander?
Yes, I mentioned earlier that one of the most predictable movement is the expansion with the aligners. But in some cases, if you have like 1 or 2 of the molars which are in crossbite, and especially as we move distally, the power of the aligner becomes weaker. So if we're expected to have distal expansion in the second molar, it's really difficult to be achieved without having the clear expander. So for premolars, expansion is very predictable and achievable with aligners by itself. But the more we go distal, the more we go to the back, the aligner material itself becomes weaker, and there is also no anchorage to help in the expansion. So I would advise to have the clear expander in those cases, especially when you have to expand in the posterior teeth.
Thank you, doctor. And a new question we got is that is anchorage loss for molars is always anticipated with distalization?
Yes, definitely, because we know for every action there is a reaction. So when we start distalizing the molars, the anteriors tend to procline, and when we try to retract the anteriors, the molars tend to move back mesially. So yes, definitely anchorage loss is anticipated, and we need to address that and reinforce the anchorage. So as I mentioned before, what Smartee solutions are offering is the clear NANS during molar distalization to reinforce the anterior anchorage, and at the subsequent stage, when you want to retract the anteriors, we can add the clear TPA at the molars to prevent them from tipping back mesially.
Okay, another additional question. So what about molars uprighting in mesially titled ones? Is it a weakness for clear aligners, and should we include fixed appliance as hybrid?
Yes, for tilted molars and uprightening of the molars, I believe it's one of the difficult movement to be achieved by aligner by itself. So I wouldn't risk having this movement done by aligners. I would definitely go for fixed or hybrid segmental arch just to upright those molars. You can try it, but I think it's not easy, especially when you need to move the roots significantly. If uprightening only involves like distal tipping of the crown, so that might be easier. But if you want to upright it with a significant root movement, I wouldn't risk doing that with only aligners.
Thank you, doctor.
Let me give you some reminder about, I mentioned all those solutions, but just to have a thought that those solutions are some of them are not with the standard GE Smartee. So if you're planning to do distalization, you have either to choose Smartee Alpha or GS, because some of those solutions are offered only with these products. So I believe with the Smartee GE, only Smartee buttons can be involved. But honestly, we're trying to reach the manufacturing company and asking them if we can have those solutions even with the simple cases. So let's see in the future if they can help us adding those.